Let's talk about an example of relative motion. This is the right foot, right big toe. We extend the right big toe, the bone right here. Big toe goes up, this bone goes down. The ball of the big toe goes down. Okay, so big toe extension, toe up, ball down. Okay, that's relative motion. So let's say if I don't have the capacity, or I don't have the ability to extend a toe, which is this motion, I'm going to reorient the whole foot, or just reorient the whole body, so I can get the foot forward. Okay, this is what they call late propulsive stage, when you push off your foot to progress forward. If I don't have toe extension, it doesn't matter. I'll just lift the whole foot forward. Okay, so relative movement is important because it allows for force dissipation and force production. If not, the compensation is usually an orientation of the whole segment or the whole body part or the rest of the body. Problem with that is that it decreases your capacity to dissipate and produce forces. Another issue with that is over time, those forces have to be absorbed and produced somewhere. Accumulation effect. So let's say, in this case, a lack of big toe extension leads to a lack of ankle dorsiflexion, could contribute to right hip pain or right hip labral tears or just labral issues. And that is a classic example where someone, instead of grounding with their feet and having relative motion from their feet on up the chain, they start grounding at the hip. And you'll see these people where they feel like they have this compression in their hips. They go to the doctor, they have a torn labral tear, you're going to need arthroscopic surgery, or in really extreme cases, just advanced osteoarthritis over the years and need a total hip replacement, which isn't a bad idea. Total hip replacement is a marvel of medical technology. It's just that what if we're able to address some of the underlying relative motion issues that may help.
So now that we discussed relative motion using the foot as an example, let's talk about hip labral tears or hip labral issues. So this might be an unpopular opinion, but maybe hip labral issues are when we overemphasize that the hip joint is a ball and socket joint rather than a socket and ball joint issue. Okay? So here's my skeleton model. This is the right leg. Here's the pelvis. Here's the femur and the rest of the leg. And let's use the squat example. So if we go down into a squat, there's going to be a certain degree of hip flexion. So when the femur moves into hip flexion, there's going to be a relative motion of what's going on at the pelvis. All right? So as we get to 90 degrees and we go deeper, there needs to be that relative motion at the pelvis. Socket and ball relatively relationship with each other under deeper degrees of the squat or hip flexion, right? When we lose relative motion, things start to happen. Like I mentioned with the foot, you either don't move any further and or you start to reorient. So another classic example is the butt wink. So when you go into the bottom of the squat, you don't have the relative motion for hip flexion, and at the socket or the pelvis, the whole pelvis will reorient, and there you get the butt wink. It'll tuck under, okay? So again, to remind you, the thing about the importance of relative motion is it allows for optimal force dissipation and force production. If you don't have those relative motions, there's going to be a compensation into orientation, and you're going to have a lack or a loss of your capacity to dissipate and produce forces, and that's going to accumulate somewhere else. All right? So rather than, not saying it's not going to help, it will, it can possibly, emphasizing the ball or the femur or the hip, doing all these exercises for the hip extensors, the glutes, the hip flexors, the groin, whatever, you know, the pelvis over here has a lot of muscles, big players that attach above it and below it that affect that relative motion of the socket and the ball. So it's a socket and ball joint issue, relationship issue, not just a ball and socket where the labrum gets wear and tear or gets abused, and that seems to be the underlying, or that seems to be the prevalent or popular diagnosis, that people get lost in those trees rather than look at the forest of things, that you have to address both ends, okay? So let's put it all together in an actual case study or case that I just saw earlier today, where a client came in, complaints of right hip pain at the bottom of the squat. He can only squat to about 90 degrees of hip flexion. So he would squat, have the pain, and he would have a noticeable shift to his right at the bottom of the squat. And got him on the table. And what we found was the pain was specifically where the anterior gluteus medius muscle on his right inserts onto the pelvis, okay? And so he had limited hip flexion, range of motion, limited internal and external rotation as well. And so we cleared whatever soft tissues we found to be in relationship to muscles on the pelvis as well as the hip. And we then gave some neuromuscular re-education drills on the table to start to reinstall some of that relative motion of the socket and ball joint relationship issue. And then we had him stand up and put him in some positions for his squat. He was able to squat again after the table stuff, after we cleared out the hip with manual therapy, and he was able to squat to 90 degrees. That's where he started to feel some discomfort. It was less, and he was able to actually squat deeper to the bottom of the squat. Pain was still there, but didn't increase. So he would get to 90 degrees, feel pain, go deeper. Pain would still be there, not go away, but it would not be increased. So we progressed the exercise into putting him in a position to be successful to get that relative motion of the socket to the ball, or basically pelvis on the hip. And we did a front foot elevated squat with the right foot forward. And what we found was his ankle, right ankle, into dorsiflexion was limited. So everything improved, but there would still be a little bit. So we did the front foot elevated, and then we added the heel elevated. So we take the ankle out of the equation, and he was able to get his knees over the toes and a lot more relative motion of that pelvis to the hip. So basically able to get to deeper levels of the squat on that right, absolutely no pain, okay? So then, could have stopped there. Squat was good, but after a few reps, he would get the pain again. Even when we unloaded it with a band, he was able to eliminate the pain, but just his body weight alone, after a while, there would be some fatigue and he would start getting stuffier. So then you have to start thinking, how do we integrate this to something he does thousands of times a day, which is walking, human locomotion, or just relate it to the gait pattern. So maximum ankle dorsiflexion is usually from late mid-stance into heel off, or just during the late propulsive phase of gait, okay? When we step forward and back leg before the heel comes off, we need that maximum ankle dorsiflexion. What we found, here's the foot again, he didn't have big toe extension, okay? So he wasn't able to access his ball of his big toe, and he would just reorient his whole foot and then just push off the big toe rather than the ball, okay? The relative motion of the metatarsal over here and the big toe itself. So he would just feed into not needing any more ankle dorsiflexion, and then that would feed into his hip issue, right? So we went from someone who has a pain in the squat, related it to his gait patterning and how that's feeding the pattern. So you could do everything at the hip, you can mobilize his ankle, But if he didn't catch that big toe in relationship to something he does thousands of times a day, it would always come back into a loop. So mobilized his ankle, little mobilizations with movement, a la Mulligan's. Then taught him some exercises to actively, by himself, mobilize his big toe and the first metatarsal. And then we integrated everything into a single arm cable push, where we put him in a stance with his right foot back, shifting his weight from his right to his left, emphasizing pushing off of the ball, not the big toe, but the ball of the big toe, as he shifts onto his left back outside heel. Okay, so it's important to integrate everything, and obviously we did it under load with the cable, resistance with that right arm pushing forward, so that this way his brain or his nervous system was able to tie things together. Okay, so that was just a quick, somewhat quick case history where we emphasize the importance and the value of addressing relative motions, and we're able to look at specific trees so that we can address the whole forest, and we can have a greater understanding of, kind of like the infinity sign, where we looked at both ends of the spectrum when we make contact with the ground, and how do we use gravity and navigate through space as we move forward in life. So in this case, he wasn't having such great grounding in his right foot, so he found the grounding in his right hip. And when he squats and he shifts over to the right, because that's where he feels the most stable, okay, the most secure. So he's getting security where his symptoms are because of the limited or fragmented information he's getting from his feet to the ground, right? So it bypassed everything, took away that relative motion, reoriented the whole body, and all those forces that normally would be dissipated before it hits the spine goes right into his hip, and that was his issue, okay?